Questions? Okay, let's move on to the next speaker. Next we have Dr. Gregg Fonarow, Director of the Amundsen Cardiomyopathy Center, who will be speaking on new and emerging therapies for heart failure.
So it's a pleasure to be here. As you've heard, we certainly have a number of well-established therapies that can improve outcome and reduce symptoms for our patients with heart failure, but there's clearly a need for additional therapies in this patient population. Here are my disclosures related to this presentation. I certainly will be discussing some off-label use of medications and devices and those that are still experimental. So as you've heard, heart failure results in substantial burdens, a high prevalence, a high incidence, tremendous cost. And despite the treatment advances, there still remain substantial unmet needs and new and novel therapies are needed. There's also the personal burden of heart failure where our patients have their congested symptoms, activity limitations, a marked increase in arrhythmias, frequent hospitalizations and rehospitalizations, and a markedly reduced survival. So that prognosis with heart failure by the natural history with over 50% 5-year mortality, although there have been improvements, patients remain at substantial risk. And particularly our patients that have been hospitalized with heart failure have an incredibly high rehospitalization rate, with 1 in 5, 1 in 4 rehospitalized within 30 days, and 1 in 3 patients after a heart failure hospitalization, even if seemingly mild and they stabilize, will no longer be with us within a year. So I don't think anybody can look at these recent statistics and say more doesn't need to be done for this clinical syndrome. Now, fortunately, for our outpatients with heart failure and reduced ejection fraction, as you've just heard, we have a number of evidence-based guideline-recommended therapies that can substantially reduce the risk of mortality. And in fact, 5 of these 6 therapies also reduce the risk of rehospitalization. So we have ACE inhibitors and ARBs, beta blockers, aldosterone antagonists for African American patients with heart failure and reduced EF, hydroxyzine and nitrates. For select patients, cardiac resynchronization therapy and ICD therapy. So a foundation of the management for those with indications using these evidence-based heart failure therapies. So what are some of the newer and more promising therapies that can offer incremental benefits to these well-established therapies for those with heart failure and reduced EF? I'm going to cover a few of them that are listed here on this slide. Now, we know how remarkably effective for heart failure and reduced LVF our neurohormonal antagonists have been. The renin-angiotensin-aldosterone system and sympathetic nervous system, the benefits of ACE inhibitors, ARBs, aldosterone antagonists, and beta blockers. So what if we move upstream? We now have direct renin inhibitors, antagonists available for hypertension. Would that offer incremental benefits to our patients with heart failure? So here's one of the initial studies looking at the direct renin inhibitor aliskiren, studying in patients with mild to moderate heart failure already on standard neurohormonal blockade, and aliskiren versus placebo added. And as you can see here, one of our commonly utilized biomarkers, BNP, there was significant greater reductions with the direct renin inhibitor versus placebo. There were also some favorable changes seen on the echocardiogram. So this was then subjected to a larger scale outcome clinical trial called Astronaut that was recently presented and published in JAMA, looking at patients in standard heart failure therapies, hospitalized with heart failure, reduced ejection fraction, looking at whether there was incremental benefit of adding the direct renin inhibitor for outcomes, cardiovascular mortality or CV death in these patients or rehospitalization. And you can see for the primary endpoint in this trial, unfortunately, while there was a trend in the right direction, no significant improvement in clinical outcome. So here's a neurohormonal antagonist strategy that we thought was very promising, that biomarkers seem to indicate may in fact benefit these patients. When we have the large-scale outcome trial, we did not see a significant improvement. There continues to be a trial looking at outpatients with chronic heart failure, but certainly for the hospitalized heart failure patient, did not improve outcome. Now, we talked about the very high risk for patients hospitalized with heart failure, and beyond our standard chronic heart failure therapies, every single trial that has been done using a therapy specifically for acute decompensated heart failure, not a single one has demonstrated improvement in clinical outcome, trial after trial that has failed. More recently, however, we have studies that have been done with relaxin. Serorelaxin is the recombinant form of relaxin-2, a vasoactive peptide hormone that is actually occurring naturally and is markedly increased during pregnancy and mediates the hemodynamic changes that occur during pregnancy so that the pregnant female can accommodate this increase in volume expansion with appropriate increase in cardiac output and renal blood flow. So it has a whole variety of biologic and hemodynamic effects. In some early heart failure studies, it had favorable vasodilating effects. And in a phase 2 study, it was safe and well tolerated. So the RELAX-AHF trial was designed to look at this in a larger scale for symptom relief as well as further safety and outcome data. And what it showed, added to standard therapy that is often IV loop diuretics and continuation of oral heart failure medications for these patients, excluding those with hypotension or in cardiogenic shock, is using the area under the curve kind of methodology and reported symptoms of dyspnea, patient-reported changes. There was greater improvement with serorelaxin than with placebo. But what is most promising and intriguing about this data set, for the very first time has been observed in a trial, here looking at 180-day all-cause mortality, a substantial 47% reduction in all-cause mortality added to standard care versus placebo. So a very intriguing finding. This is, however, just one study. The p-value is just 0.02, and this will need to be replicated. But we may be on the verge for the very first time having a therapy, an intravenous therapy given for a 48-hour infusion that can improve clinical outcome for patients hospitalized with decompensated heart failure. So very promising, not yet available, needs confirmation, but very, very exciting. Now, anemia in heart failure has intrigued the heart failure community for over a decade. We know it's pretty common in our patients with chronic heart failure. We know in the extreme anemia can cause heart failure. We know heart failure in itself can be cause of anemia. But whether the anemia was actually contributing to the symptoms and adverse outcome in our patients with heart failure, or is just a marker along for the ride, was really not well known. We had seen studies like this that was done at UCLA where the lower the hemoglobin level, the worse the outcome. And even when you'd adjust for the severity of heart failure, you saw this greater independent risk to mortality. And so this intriguing idea that we could treat this anemia and make our patients with heart failure feel better and live longer. The Stamina trial was a trial to look at whether there could be exercise improvement in treating patients with mild to moderate anemia, hemoglobins in the 9 to 12.5 range, heart failure on standard heart failure therapy, using one of the newer ESAs, darbepoetin alpha. And what showed was there was a trend for an improvement in exercise duration, but this did not quite reach statistical significance overall in the placebo-controlled arm. But those patients that seemed to have a greater improvement in their hemoglobin, 2 grams per deciliter, compared to those that were either on placebo or didn't respond to the ESA. So there was some improvement in exercise capacity and favorable trends for clinical outcome, but clearly not statistically significant. We now have the data, though, from the RED-HF trial, a prospective outcome trial looking at darbepoetin alpha versus matching placebo in patients with mild to moderate anemia. and EFs 35% or below, and on standard heart failure therapy with the primary endpoint time to death from any cause or first hospital admission for worsening heart failure after randomization. This was an event-driven trial for at least 1,100 events, so well-powered and over 2,400 patients randomized. And what you can see here with regards to clinical outcome, that in fact the addition of darbepoetin alpha to these patients did absolutely nothing for improving clinical outcomes in these patients. No reduction in death or first hospitalization, no reduction in the individual components of this endpoint, and really not much impact on quality of life or symptom standpoint. So we've answered this question: can we improve outcome for our patients at mild to moderate anemia in their heart failure with the improvement in their hemoglobin through this mechanism? And in fact, the answer is no. There was a lot of promise and excitement around the use of statins as a treatment for heart failure. There have been a variety of studies demonstrating pleiotropic effects of statins experimentally, and the idea that in fact we could utilize statins to alter remodeling and as a treatment for heart failure, not just as a treatment for coronary artery disease. And some intriguing data from our post-MI studies, patients with LV dysfunction post-MI seemingly deriving a benefit of statin therapy here from the CARE study, but of course this may just be all preventing recurrent coronary events. But a variety of experimental data suggested that statins could have a direct effect independent of their cholesterol lowering. We now have 2 large-scale randomized outcome trials. This is the Corona trial, looking at rosuvastatin versus placebo in patients with coronary disease and heart failure. And you can see for CV death, non-fatal MI, non-fatal stroke, a trend in the right direction, but no significant reduction, and certainly not any improvement in any direct heart failure-related endpoint. So unfortunately, statins, although they may still have a role for coronary disease in our patients with heart failure, did not have a major impact on their heart failure outcomes. There has been a lot of interest around omega-3 fatty acid supplementation. This slide shows a variety of the mechanisms by which omega-3 fatty acid supplementation, basically fish oil supplementation, could be beneficial in patients with heart failure. There's anti-inflammatory effects, potentially neurohormonal modulation effects, antiarrhythmic effects that could be beneficial in our patients with heart failure. There had been some small studies that looked intriguing. We do have the large-scale outcome trial, GC heart failure, 1,000 milligrams of omega-3 fatty acid formulation, the same one that was used in the GC prevention trial. And there was a very small effect seen here. An absolute risk reduction of 1.8%, number needed to treat of 56, a relative risk reduction of 9%. However, this therapy was safe, it was well tolerated, it was relatively inexpensive, so this may be a consideration for a therapy that can be utilized in our patients with heart failure regardless of etiology, but the benefits, as you can see illustrated here, are quite modest, but are recommended in the guidelines at either a 2A or 2B level of recommendation. Now, there's been a lot of interest in the nitric oxide paradigm in heart failure. And so we know that the vasoconstricting neurohormonal systems work through a cyclic AMP-dependent mechanism. Counteracting these are vasodilating and growth factor inhibiting factors such as natriuretic peptides, bradykinin, or directly releasing nitric oxide, and this idea that augmenting these could be beneficial. We know that one of the mechanisms by which the combination of hydralazine and isosorbide dinitrates work is through an NO-dependent mechanism. And in the AHAF trial of 1,050 African-American patients with heart failure on standard therapies where hydralazine nitrates were added to the regimen, there was a remarkable 43% reduction in mortality. So certainly this group of patients benefit. Interestingly, and not well understood, non-African American patients have not seen the same type of benefit with hydralazine isosorbide dinitrate. So whether this represents differences in genetic polymorphisms, other factors not well understood, clearly a therapy we should apply for our African American heart failure patients selectively can utilize in other patients based on ACE inhibitor intolerance or for vasodilation, as Dan Cruz just showed you, but an intriguing finding. Are there other ways, though, that we can enhance nitric oxide synthase and NO release? And in fact, we can inhibit the breakdown that occurs at guanylate cyclase in binding to receptors after NO stimulates the release here. And so phosphodiesterase 5 inhibitors could be a mechanism by where we can enhance nitric oxide dependent cyclic GMP. And there's a variety of experimental data that show that you can block the heart failure remodeling process and cardiac hypertrophy. And in fact, symptom rise in patients with heart failure. Here's a study giving a 50 milligram dose of sildenafil, and you can see that there was an improvement in exercise capacity in these patients. And it was thought that potentially those patients with heart failure and preserved EF would derive the greatest benefit with this type of approach. Unfortunately, we now have the results of the RELAX-HF network trial. This was presented at ACC, published recently in JAMA, where they looked at sildenafil in patients with heart failure and preserved ejection fraction. No improvement in exercise capacity, no improvement in overall clinical status, no improvement in biomarkers. So unfortunately, despite this appearing to be a promising therapy, at least in heart failure preserved EF, did not improve clinical outcome. Whether there will be a benefit in heart failure reduced LVF, there's a large-scale trial being organized right now called PITCH-HF. We will get the answer, but the enthusiasm level for this trial has gone down. Now, there is an agent available in Europe that is not yet available in the US that's very intriguing, and that is direct heart rate lowering using this drug irabidine, which is a specific inhibitor of the IF current of the SA node. And all it really does is lower heart rate. And here is the results of the SHIFT trial, where patients, despite beta blockade, had heart rates that were above 70, and these patients seemed to derive benefit of having their heart rate lowered. The greatest benefit were those with resting heart rates above 77. So this may, why not available for us now, tell us for our patients with heart failure that we haven't gotten their resting heart rate below 77, we should up-titrate their beta blocker even further, up and above standard doses, in that heart rate in of itself is an independent predictor of outcomes. Now, if we look in real-world clinical practice, despite the available therapies, there has been only a modest improvement in survival in real-world heart failure patients with reduced ejection fraction and no improvement in those with heart failure and preserved EF. So although we've had a number of therapies that markedly improve outcome, many real-world patients are not receiving these benefits. And a lot of this has to do with the treatment gap. They're not being actually treated with these therapies. And some of this has to do with clinicians questioning whether the results of randomized clinical trials for ACE inhibitors, ARBs, beta blockers, aldosterone antagonist device therapy apply to my real-world patient in my clinical practice. Maybe my patient's more unique. Do we know these drugs, while they're efficacious in trials, are really effective in real-world patients? We were able to provide this data from IMPROVE-HF, where we were able to show individually and in aggregate the improvement in real-world clinical heart failure patients with reduced LVF with the use of these agents. Every 10% improvement in guideline-recommended heart failure composite care associated with a 13% lower risk of 24-month mortality. More recently, we've demonstrated the cumulative benefit of these therapies. As we add each of them to each other, we can get an 80 to 90% reduction in all-cause mortality in our patients with heart failure and reduced ejection fraction. Compelling data for why we need to apply these therapies in real-world practice. But what about the real advanced patients? Have there been improvements in survival here? This is data looking at survival in patients referred to the Amundsen UCLA Cardiomyopathy Center from 1993 to 2010. And as we've been able to apply these advances in medical therapy as well as the ability to transplant in bad patients, there has been successive improvement in risk-adjusted survival in these patients, dramatic improvements in clinical outcomes over time. So even for the most advanced heart failure patients, we've been able to remarkably improve clinical outcome, though certainly when you can see the most recent AIR survival curves, there are still opportunities to further improve outcome. What if we took all of the clinical evidence we have now that's been synthesized in our guidelines and made sure that all of our eligible patients without contraindications or intolerance with heart failure and reduced LVF received each of these therapies in the absence of contraindications and intolerance and with optimal implementation and monitoring. Here is the survival advantage with each of the individual therapies and in aggregate, and I think you can see here that altogether there can be as much as 68,000 deaths prevented each and every year that otherwise are happening that would be eliminated with better implementation of just our existing heart failure therapies. So implementation of our evidence-based therapies is absolutely critical. The impact that we can have for our individual patients in applying these therapies is profound. Together, if all therapies are used, 80% reduction mortality in relative terms, 28% absolute risk reduction, number needed to treat to benefit, a very remarkable 4. Now, I recognize not every patient tolerates each of these therapies, and even a 7% 2-year mortality rate is still too high. So we need further research and additional therapies. We need the advanced therapies you will be hearing about over the course of the day. But this is compelling data for why we should be implementing each of these therapies. So the burden of heart failure continues to grow. It is one of our most deadly and expensive healthcare problems. Medical therapy and non-pharmacologic measures for heart failure can impact patients' need for rehospitalization, cost of care, and survival, but they're underutilized in conventional practice settings. Every effort should be made to implement our evidence-based guideline-recommended therapies, and certainly further research into more promising therapies for heart failure is needed. Thank you very much for your attention.
Thanks, Dr. Fonarow.